My name is Les Jones. I'm joined today by my usual colleague on these events, Rebecca.
Hi.
Rebecca is our clinical lead. Subject of today's webinar is postural care and the top 10 things to know. It's going to be mainly a PowerPoint presentation. We'll stop at the end, take some questions. If you've got questions as we run through the presentation, please use the chat feature. And my colleague Jess, who's working in the background, will endeavour to answer as many questions as possible. If not, we'll pick them up at the end. If you have any technical issues, we tend to find the best way to resolve this is leave and rejoin the meeting. It tends to reconfigure your settings and it just makes things run that more easily and smoothly. If I leave Rebecca wander off to start to set up her presentation. A little bit of housekeeping. We are recording the session, so your mics and cameras should be switched off. After the event, we'll send you a link that will give you a copy to the presentation. So if you've got any colleagues who can't make this morning, we can send you a link so they can watch it in their own time. Are you okay, Rebecca?
Yeah.
So I'm going to hand you over to Rebecca and I shall see you in about half an hour, 40 minutes or so.
Thank you, Les. Let's get this onto the full screen. There we go. So as I said, it's really going to be mainly a presentation with myself this morning, having a look at the theory behind postural care and some of the top 10 things that we think that you should know about postural care. This is kind of a baseline introduction. If those of you who want some information on further reading, the reference list is at the end as well. But if you want any advice around that or where to get more support, if you want to learn more about postural care, a bit more in depth, a bit more in detail for complex cases, then again, just use the chat function and you'll have our email address as well when we send the presentations out. So really, I just wanted to start, as we always do, just by setting the scene. We've got a range of different people joining us this morning from different specialties, different areas of expertise, different experience. So we just set the scene quickly just around what we mean by posture first, and then we can have a look at postural care and how we support it. Now, the body itself, as we know, is multi-segmental. So the body structure is highly flexible, which is fantastic because it means we can adopt all these different positions that we need to do throughout the day and night for different activities and engagement and so on. But that does mean that it's inherently unstable, and it means it is vulnerable to damage as well. So when we talk about the body structure, it's quite a complex system. So to be able to break it down into these manageable proportions, we can look at it as a system of segments. And you can see it all labeled there. Of course, for seating, the foundation is that the pelvis segment, because it dictates what happens above and below. But with all forms of postural care, even in seating, we still need to consider every other body segment, even down to the feet. Now, posture is essentially the way that we position those body segments, the way we adopt different positions with our body structure in relation to one another, but also their orientation in space as well. And there's two main purposes to posture. So we've got the anti-gravity, so the ability to remain erect and rigid against the forces of gravity. So to remain upright in that functional position for sitting, of course, but then for mobilizing, for other activities, remaining balanced and stable and so on. But then, as we said, it's also that interaction with the environment as well, making sure that we can engage and participate, reach outside of our base of support and remain balanced and stable. Now, as we grow and develop, we learn from and respond to lots of different information that's sent from lots of different sources. So our visual system, our vestibular system, our balance, our proprioceptive input, and knowing where we are in space. And when we have any damage to these systems, that's what then affects our ability to interact with the information. So when we think about the type of individuals and the client groups that we work with, and the damage that they can have to their body systems, and how difficult it is then for them to understand that information and to be able to achieve protective postures. when we think about the body structure and how it distorts, there's 4 key areas that we need to think about. So, of course, the inability to change position. If that positioning is then asymmetrical, we've then got the influence of gravity on top of that. Now, gravity is unrelentless, as we know, and if I made you sit in one position for 10 hours, you'd soon start feeling the effects of gravity. At the end of a long day, when you sat on the sofa and you slumped down into that position, it's really difficult to hold ourselves upright against gravity. So when we think about the individuals we work with who may have issues like low tone or poor postural control, how difficult it actually is to fight those forces, those gravitational forces, because then what happens is it tends to exaggerate those asymmetries even further. So you've got this vicious cycle then of body distortion. So that's really just a really brief introduction to what posture is. We've got lots of webinars where we've covered posture. We've got resources on the website as well. So if anyone's got any specific questions about posture itself or wants any more further reading, again, use the chat function or get in touch. So our top 10 then, we're going to do a bit of a countdown like a chart here. Starting at the top with what we mean by postural care, all the way down to then our favourite keyword, the holistic approach, and how we really maximise that postural care. So what is postural care? It's essentially the use of any technique that we use to minimise postural abnormality whilst enhancing functional movement. So as an approach, what we're aiming to do is preserve or actually even restore body shape for individuals with movement difficulties. Now, body distortion isn't inevitable. And as long as we have we risk assess, so we think about proactive postural care and we get the right equipment in at the right time, then we can protect body shape. Now, it's critical that we identify, as I said, we identify that risk and implement the interventions as early as possible. And when I said about these interventions, it can be anything from positioning aids through to individual programs. It could be aquatic therapy or rebound therapy to do with individuals, orthotic devices. It's any intervention that's part of that holistic care to protect their body shape. But we need to think holistically about determining those who are at risk of achieving good protective sitting postures. And then we utilise resources then to determine the need for a specific postural care pathway. But as we go through the presentation, we can have a look at maybe some of the barriers that people experience as part of that. So who needs postural care? Break it down into 4 different areas. I mean, the first one is probably the most obvious one. And what we do is we think about those who actually lack the physical ability to be able to change position themselves. Those with movement difficulties, where they actually lack the active engagement to change position. But then because we need to think holistically, we also have those who lack the cognitive awareness. So those of you who might work with individuals with dementia, for example, or learning disabilities, maybe they lack that cognition to know that they've been sat down for a long period of time and then maybe they need to change position. There's those who lack the communication skills to convey that they're uncomfortable. So they might be completely aware that they're uncomfortable, they need to change position, but there's no plan or support in place for them to be able to communicate that to their support network, to be able to be supported to change position. And then there's those who lack the sensory feedback then to know that they need to change position. So again, thinking about that proprioceptive input and not knowing maybe where their body is in space, not knowing that maybe gravity has made them slump over to one side, and not getting that sensory feedback to know that they need to change position. And this is a really critical part of pressure care then as well. So when we break that down to the type of client groups that we work with, I mean, this list isn't exhaustive, but if we think about some of the individuals we work with, I know we've got a range of people joining us this morning from different specialties. But what we're thinking about are things like not neurological impairments, those with little or no active movement. So maybe those with cerebral palsy who lack that active movement, altered body shapes, maybe people who have developed contractures or deformities that make it difficult for them to change their position, movements that are difficult to control, ataxic movements, choreic movements like you might see in Huntington's disease can make it quite difficult to maintain protective postures. Sensory impairments, which we've covered, impaired proprioception, communication difficulties, cognitive impairments, those with swallow dysfunction, so maybe if they have dysphagia, we need to be mindful as well of how that can impact on their postural care and what might be safe or unsafe postures for them to adopt. Impacted physiological function and poor skin integrity. So again, it's not just focusing on the physical, but thinking holistically about all those damage to different body systems that could impact on their ability to achieve protective sit-in postures. What this can also mean as well when we think about some of these damage to the body systems is individuals who maybe their health deteriorates and they end up spending a lot of time in sitting postures or even in bed. Aging, another factor we need to be mindful of as well, because aging does have an impact on the body structure. People can present with things like generalized weakness, limited participation and deconditioning, so we need to be mindful of that. And even those, again, if those of you who work maybe in palliative care, individuals spending prolonged periods in one posture and how that then might impact on them, their overall well-being. So when we think about the damage to the body systems, thinking holistically and how that impacts on them. Number 9, we have, so why is postural care so important? But posture is directly related to our health, our well-being, and ultimately our quality of life. And there are going to be physical, psychological, and emotional effects of body shape distortion. And ultimately, if somebody doesn't have optimum postural care, it can have severe and life-threatening consequences. And we're starting to see a shift now in the research, in the evidence base, and in the legislation around it to try and promote postural care as a critical part of that care pathway for them. Now, in terms of the physical impacts, these are some of the things that we might see. So individuals experiencing pain, fatigue, when we are adopting asymmetrical positions, or if there is an underlying generalized weakness, then obviously it can make it quite exhausting to be able to maintain that upright sitting position against gravity. So when the body systems and the body structure don't work together efficiently, that's when individuals become fatigued. We might be working with individuals who maybe have lacked postural care in the past, and they're already presenting to us with complex deformities, which can make that difficult. We've got the physiological impact as well. So we think about the distortion and compression that can happen at the lungs, at the internal organs, and how that impacts on the ability to breathe effectively, to be able to digest, because see things like constipation. If people are sitting for prolonged periods of time, we've also got the skin integrity issues, especially if they've got other factors as part of that, intrinsic factors that affect their skin integrity, things like their diagnosis, their medication, incontinence, and so on. Polypharmacy, and then sadly, premature death. So there was a confidential inquiry into learning disabilities, and what they found was that around 50% of individuals with a learning disability die prematurely from respiratory related conditions. And as we know, posture can have a direct impact on their ability to breathe effectively. Without taking the tone down, this is how serious it can get with postural care. It's not just about getting people to sit out and engage and participate, it's actually protecting their health and safety as well as reducing that risk of premature death. Now, research has shown that this inability to maintain an upright sitting posture is associated with a decline in our health. And what we might see with individuals we work with is things like the developing of pressure injuries, because see recurrent respiratory infections or digestive problems, which then could put them at an increased risk of severe infection, hospital admission, and even surgical interventions. From a psychosocial impact, when we think about their well-being, some of the factors that we might see if we don't have optimum postural care, things like isolation. So we said about individuals maybe who are developing really complex postures. I don't like the term unseatable, but what we might do is somebody who's lacked postural care, and then they're coming into the service, or maybe they haven't been identified as at risk of postural care, or they've become unwell and they're confined to their bed for a period of time, and the isolation that can come with that being contained to the four walls of their bedroom, and how that can then impact on well-being. We might see an increase in dependency, so individuals might be more dependent on this support network, especially with things like moving and handling and transfers, the need for more expensive and more invasive equipment to be able to complete transfers into and out of equipment. This can make accessibility an issue, especially if individuals are then sadly become non-ambulant. It can restrict then their ability to go out into the environment and participate in social activities. We can see low mood and low confidence, and with that then comes low motivation. So we want people to, we want to be person-centered, but we want people to have an active part in their care as well. If people lack that mood, that confidence and that motivation, then sometimes it can be difficult to get them to follow care plans and be an active part of that. Now, when somebody finds it difficult to sit out comfortably, as we said, it can mean them becoming confined to their bed and the four walls of their bedroom. And research has shown that loneliness and isolation is actually twice as harmful as obesity to physical and mental health. So quite shocking statistics there. And why we need to encourage that postural care and a change of position through different bits of equipment and through different environments for the psychosocial impact. So number 8, we have the benefits of postural care. So we know why it's important to manage somebody's posture, but in terms of the benefits, we know it's clear benefits in health and well-being and the quality of life of the individual, but it also reduces the need for intensive, invasive and often expensive interventions as well. So thinking about complex equipment and specialist equipment that might be needed, increased care packages that might be needed, surgical interventions if people develop quite severe deformities, or if people have recurrent hospital admissions and the cost of day beds. So we need to be really mindful, not just the individual, but actually the cost effectiveness. So you've got the human cost alongside the cost effectiveness for the wider economy as well, because we want to make sure that we've got longevity of services and resources for a long time to come. So we need to be mindful and sensible with how we use those resources as well. So it's about thinking about those long term, and sometimes that could be a difficult part of our clinical justifications and our funding requests. We have done webinars specifically on that as well, so if anyone wants information or support around funding requests, then just pop in the chat or message us, because that's another whole other webinar that we've done that I could digress onto right now. So if we have effective postural support, we can enable the individuals that we work with to engage and participate in all the activities that they want to engage in, the hobbies, their occupations that are important to them and their well-being. We can encourage physiological functioning, they can eat and drink safely, but also communicate effectively as well, and that's a really important part of their well-being. So what we're aiming to do is promote that longevity and make sure that that's the key preventative measure to reduce the risk of secondary complications. Now, some of the barriers that we might come across as clinicians, I mean, the top one is probably that lack of awareness, and that's why we do these monthly webinars, and this is why we keep going on about the need for good postural care. This is why we do our blogs, our articles and our newsletters. We go out and about to training events and really push the message about postural care and play our part in that, not just about the sitting aspect, but actually how that integrates into the full 24 hours as well. Lack of resources. I mean, we do travel, myself and Les, we travel around the country, and we definitely see a difference in different areas and different teams. But again, maybe that lack of awareness, and hopefully we're seeing a shift in the research and the evidence base. And also the people who are now interested in postural care as well and know that it's a specialty to get involved in. Hopefully we can see that starting to balance itself out. There's a perception as well of medical equipment, and that's something that we've covered in past webinars before, especially when we have a look at the holistic approach later. But there's definitely a perception about, especially maybe from the individuals themselves and their support network, and how they accept and be compliant with equipment, especially with a new diagnosis or a progressive diagnosis, if they've not been around medical equipment before. Things like specialist seating, nighttime positioning can seem quite scary to some individuals. Is it something new? Is it something that's going to hurt? Is it something that's going to restrict them? And it's just about really setting the expectations beforehand. Even things like just before a visit, it might be worth sending out videos or brochures or images of equipment, case studies as well, to show how actually it can help individuals and how it's helped individuals with similar challenges to them, to really just set that expectations and try and change that perception a little bit. Postural care should always be humane. It should not be painful. It's a gentle approach to protecting their body shape. Illness or hospital admissions can be quite a big barrier as well, especially like we've said, in terms of how it can impact on an individual's ability to be able to sit out, as an example. If people are unwell or spend time in hospital away from their usual support network and away from the usual care plans, then we could lose that momentum that we've had with their postural care, with their 24-hour plan, and sometimes it can set people back as well. I think they say it takes around 3 days to lose 3 months worth of strengthening and conditioning. So that's another thing to be mindful of. And another really key example of why we need to manage people holistically to reduce the risk. If somebody is at risk of repeated hospital admissions, then how do we manage that and bring that into their 24-hour postural care plan? And I guess one of the biggest challenges is the assumption that body shape distortion is inevitable, regardless of the type of individual we work with. Is of course some body changes are going to happen, especially if we're working with those with hypertonicity, so maybe those with spasticity, high muscle tone. There are going to be some elements that do change just because of the nature of that neurological impairment. But if we can manage their posture throughout that 24 hours, identify risk, then those really complex, severe, unseatable body distortion isn't inevitable, and we need to play our part in raising awareness about that too. And it might be good actually in the chat, Les, to maybe chat about some of those barriers if anyone has got any particular challenges or any barriers at the moment within their area. It's always good as a peer review if somebody in another area has found something that's really worked. The chat function might be a good Q&A at the end, might be a good place to chat about that. So number 6, I mean, I've mentioned this quite a bit already, but postural care has to be considered across that full 24 hours. So we have to address all those body segments and positions that somebody adopts throughout the day and night. And it usually involves provision of seating, the positioning equipment that supports somebody in lying, the movement and handling techniques that get somebody effectively from different pieces of equipment, but also the advice and the training and the education that comes with that, so that everyone involved is confident, compliant, but also competent in following the care plan as well. So just as an example, there's probably quite a good visual that one part of the day is only as good as how somebody's posture is managed throughout the rest of the day and night. So when you think about nighttime positioning, I mean, if somebody spends 8 hours in bed, that's the third of our lifetime that we spend in lying. So how can we expect someone who maybe adopts a fetal, really flexed position at nighttime, maybe someone with dementia goes into that side lying wind sweeping position for 8 hours without being supported, without a regular change position, to then extend out into sitting during the day? So it's all interlinked. We need to understand that link between sitting and lying. It's believed that many of those asymmetries in body posture originate in lying, and then they're compounded in sitting. There's going to be different effects of gravity in different parts of the body. So it is going to be a different approach. And again, we've done a good webinar with Simple Stuff Works. I think that was last October. They looked at 24-hour positioning and nighttime and how that works with specialist seating. Because what we need to think about is those long periods in bed, how then gravity brings people into those asymmetrical postures, but also those poor sleep patterns that then affect somebody during the day. So if somebody's uncomfortable at night, if they're not sleeping well, they fatigue during the day, gravity has more of an impact, and we see then even more asymmetrical postures in sitting during the day. So it's really understanding that link across that full 24 hours. Number 5, we have posture and pressure, something we always get asked about. And again, I think there's definitely momentum building in terms of people understanding how posture and pressure are inextricably linked. So the way that we position ourselves, the way that the body segments adopt different postures does have a direct influence on the pressure that goes through specific body sites. Now, even in the gold standard sitting position, which I'm sure if we put everyone's screens on right now, not many of you would be sitting in this gold standard sitting position with a slight anterior tilt, the hips, knees and ankles all at 90. But even in this gold standard, we've still got 75% of our body weight going through our buttocks and thighs. 19%, believe it or not, even in sitting, going through our feet. 4% through the back and 2% through the arms. So if you think about specifically pressure care for individuals who are non-ambulant, and you go to visit someone who maybe lives in a care home, you've got a 5-foot individual using the same chair as a 6-foot individual, and their feet are dangling and not touching the floor. Or you see foot plates being used as door stops or bookends. If we don't support the feet, where does that 19% of their body weight go? You could suddenly have 94% of their body weight just going through their buttocks and thighs. If somebody then also has a pelvic obliquity, or if they fatigue and lean into one side, that could be through one part of the pelvis. It could be through one side of the one ischial tuberosity. And then we're wondering why pressure injuries are happening. So it's really key that we distribute weight evenly over the maximum surface area to reduce those interface pressures. Now, when we do sit, as we know, that pressure exerted through the skin and onto the soft tissues underneath. Now, the body can only withstand those high interface pressures for a very short period of time. So if we don't load the tissues equally, or if it's not regularly redistributed, then that's when pressure injuries happening. I mean, there's lots of different categories. Pressure injuries is just a very simple definition of it. But when the cells lack that blood flow, so it's restricted, they don't get the oxygen and nutrients that they need, that results in the cell death, which is the pressure ulcer. Very basic, very simplest terms, just to understand how posture and how the body weight can restrict that blood flow and increase the risk of pressure injuries. Now, when pressure injuries happen, the impact of it can be devastating. So we can see physiological, psychological, financial implications on them as an individual. Pressure ulcers are painful, debilitating, and of course that's going to impact on their overall well-being. Those of you who work in elderly care, pressure injuries are actually associated with a 5-fold increase in mortality, which is staggering. Now, specialist seating and postural care in general aims to reduce the risk of pressure injuries by distributing users' body weight evenly throughout the chair or the lying support surface or any other sitting support surface over the maximum surface area. They can offer different bits of equipment, can offer a much needed regular change of position as well to encourage that blood flow and redistribute the pressure. So the key factors that we need to consider, of course, optimum positioning, equal weight distribution, the correct setup of equipment and appropriate use of functions, but actually the biggest factor of this is that regular repositioning. So there's no point achieving one perfect posture and maintaining that for 16 hours because it's all about that regular change of positioning, because that's the key intervention that's been shown to to be the best and most effective method for preventing skin damage and ultimately improving an individual's quality of life. So again, that really feeds into that 24-hour approach to postural care, and using different equipment to achieve different postures and redistribution pressure across that 24 hours. Now, specialist seating, and how does specialist seating play its part in postural care? When the ability to achieve optimum protective postures is affected, so if you think about the individuals we work with, whether that's through age, illness, disability, or disease, it can have a significant impact on their health and well-being. So specialist seating aims to allow those individuals who cannot sit in standard seating to achieve their optimum sitting posture. And I use the term optimum here just because it might not always be a good posture. I'm using inverted commas there, but especially if we're working with complex individuals, there might be an element of compromise there. But as long as we are striving for their optimum sitting posture without regular change of positioning, then that's what we aim to do with specialist seating, and getting that fine balance between all those seating objectives. And just a long list, and again, we could add another few slides to this about how specialist seating can help, but thinking holistically about not only their health and well-being, but also their quality of life, the engagement, and the participation as well. But again, if somebody wants more information on specialist seating, then just pop in the chat and then we can send through some resources on that. Now, we like to break it down to 6 key principles of seating. Comfort, and I'll cover that in a bit shortly. Posture, of course, which we've covered, and how that is supported within the chair and achieving different postures from the chair. And it's probably especially important to be mindful of wheelchair users as well. So we don't want to completely, we can obviously use somebody's wheelchair prescription as a guide for specialist seating, but we don't want to completely reenact what the wheelchair does. So we need to have different objectives, different goals between the specialist seating and the wheelchair, to make sure that we are thinking about them holistically, because we don't want to just kind of replicate what they're doing in the wheelchair. Otherwise there'd be no point them having specialist seating. So in terms of the objectives, it's going to be a bit more flexible. Comfort is going to be key with specialist seating, less rigidity, but also within the environment, the home environment, rather than just a tool for transit as well. We've got pressure, which we covered. We've got function and independence. So this is not only about encouraging somebody to be as independent as possible within the chair. So thinking about their occupation, if somebody still works from home, how do we enable that with environmental controls, for example? Does somebody need a tray for communication for their PEC system? Do we need to think about maneuverability or motorized controls to keep that independence within the home? But it's also about protecting the body shape as well. So if we can encourage people to be active and have as much independent movement as possible, then we can get good joint range of movement, we can encourage blood flow, and we can reduce the risk then of deformities and contractures happening and reducing the risk of injury. So it's not just about function, but actually protection and reducing the risk of injury as well, getting people moving and active. And the more active people are, we can increase that mood and motivation as well. So that's a really key part of being an active part of the care plan and being compliant with it. We've got the safety element. So this is about their health, thinking about those physiological functions that we mentioned, making sure that we're encouraging safe feeding and drinking, swallow, that we're using equipment responsibly. We do need to risk assess certain functions, things like tilt in space and back angle recline, and not suitable or safe for everyone. Especially individuals maybe who use catheters, those who have pooling of saliva, if there's a risk of aspiration and so on. So we need to make sure that individuals are safe within the chair. Quite significant violent movements as well we need to be mindful of, and how we promote that stability within the chair, but also the safety of the support network as well, and making sure that they can use the equipment with the individual and utilize the functions and accessories safely. And then, of course, the well-being, which we've spoken about in terms of participating and engagement, and improving people's mood and all those psychosocial factors. Now, just quickly, before we have a look at our top two chart hits there, but what do we actually mean by good sitting posture? So when we think about these key principles of seating, this is just a really handy checklist. Those of you who are aware of postural care, have an interest in postural care, will no doubt have heard of Pauline Pope. This is just a really good checklist when it comes to seating or any kind of postural support, really, to make sure that we are supporting the body within the supporting surface as symmetrically as possible. We're thinking about pressure care, so body weight is distributed equally over the maximum surface area. If we can't correct the individual to equipment, do we need to accommodate by bringing the equipment to them and essentially fill in the gaps? We need the individual to feel balanced and stabilized within that piece of equipment. So that's really key. So especially in sitting, that pelvic stability, that postural stability is really key to managing some abnormal movement patterns as well. So it can help with the function and independence, but also feeling secure within the chair as well can help with that energy management. But they also need to be able to adjust to change as well. So can individuals reach outside of their base of support to engage while still remaining safe and stable within that piece of equipment? The body segments are supported and aligned as much as possible relative to themselves, but also the task at hand. And then thinking about that stability, we need that proximal stability to have distal control of the upper limbs. So we need individuals to be able to have their limbs free from that low bearing role for function. Otherwise, what we might see is individuals clinging onto a piece of equipment, digging elbows in, and that can be really fatiguing in itself. It can be really uncomfortable, but also really restrictive. And as we know, any kind of postural care has to enable freedom of movement. It has to be comfortable and a gentle approach. So just visually there, just to see the difference, when we talk about gravity, this is typically what we might see, gravity taking control, especially if individuals have that generalized weakness, pulling individuals into that slump with a head rolling. And you can see then how it exaggerates those asymmetries. What we're aiming to achieve, as we said, is not like this perfect posture, but the optimum sitting posture, with everything supported as much as possible, as much of the person in contact with the chair as possible. Of course, the feet supported so that we have that stability and that proprioceptive feedback that we naturally seek through our feet to help with that pelvic stability. The arms free from the low bearing roll so they can engage and function, but also that trunk alignment, really important for physiological function, opening up the shoulder girdle and supporting the head for safe eating and drinking, but also communication and line of vision as well. What we can see is individuals becoming losing that line of vision, and suddenly they're staring at the floor, whether they've got this kyphotic posture or fixed head positions, and losing that ability to look up and make eye contact with people and communicate. So number 2, I said about comfort. So this is really high on our list because it's actually really key for specialist seating, but postural care in general. So when individuals have prolonged or destructive postures, what we can see is tension on those body segments, and we can now see an increased risk of pain and discomfort. So we need that proper positioning to promote comfort, and there's lots of research out there on this. But essentially, if we can have this supportive, protective sitting posture, we can inhibit some of those abnormal movement patterns. So some of those tonal changes, those reflexes, trying to dampen down some of those to make sure that an individual is comfortable and they're not having the pain that could be associated with spasticity, for example, and prolonged positioning in deformities. Now, overarching theme about being comfortable is making sure that somebody is compliant. So if somebody feels comfortable, if they feel safe, then what we can see is an increased tolerance of their compliance with that piece of equipment. There's no point in us as clinicians putting all this hard work into postural care, to doing our comprehensive assessments and coming up with a perfect prescription if the individual isn't going to use that piece of equipment. So regardless of those clinical benefits that we are trying to sell to the individual and trying to get them on board with, if they're not comfortable, then they're not going to use that piece of equipment. So it kind of negates all our work that we've done. So it's really important, and sometimes it is a fine balance. We may need to compromise in areas, especially with specialist seating, to make sure that the individual is comfortable. And that's why it's so high up on our list. And this really feeds into our top number one point to take away, is that it has to have this holistic approach. So for postural care to be effective, we need to think about the whole person. We need to take into account all those psychosocial factors, all the physical impacts, rather than just symptoms of a disease. It's obviously helpful for us to know about an individual's diagnosis, because we may know how certain diseases and conditions progress. It might help with long-term planning with equipment. But as we know, those of you who might work with individuals with stroke, no two individuals will be the same. So even though this may be a diagnosis of an ischemic stroke, presentation will be very different. The same with MS, with cerebral palsy, with 4 different types of cerebral palsy. People, it doesn't matter if they have the same diagnosis, the presentation will be different. So we just approach it with the individual sat in front of us, and that ensures that person-centered care. And to make sure that we think about the well-being and quality of life as well. Because if we determine that key information about the individual, but also the support network, then that's how we get that consistent compliance. And we need that consistency to achieve our objectives. So what we need to do is think about a day and night in the life of the people that we work with. So we need to think about the care plan. What do we need to consider to make sure that people follow it, that people are happy with it, and actually that they are competent with it. What postures are adopted throughout a typical day and night. So maybe they're habitual or preferred postures, just to get an idea of where we might need to change support or try and correct or accommodate in certain areas. What activities are important to them, especially when we're thinking about seating. What do they need to do within the chair? What does the chair need to do for them? Because if it doesn't do that, something as simple as not putting a tray on could actually take away their occupation for them, or their communication ability. So we need to think about the activities that are important to them and how we make the equipment fit to that. How does specialist equipment fit in and integrate together as part of that care plan? So a key part of this would be not only transfers in and out of a chair, which can sometimes be overlooked. Different bits of equipment work better with different transfer aids or hoisting equipment and so on. But actually, are we achieving different postures through all the different bits of a specialist equipment as well, rather than just replicating and again, just maintaining the same position? And as we said, how will that integrate with one another? I've said about the support network, especially in cases where maybe there's an element of complexity, where we are relying on family members, on professional carers, to be able to carry out the care plans. The individual might need that support from another individual or from a team. So we need to involve them as well where possible, because we need to reduce that dependency and carer effort to make sure that it's compatible with daily life for them as well. And again, all about that compliance. And there's just a bit of CareFlex resources there, because I know I said a lot of me talking, I was a real whiz through of postural care, but in terms of the top 10, that's what we wanted to highlight and hopefully give you some ideas of where to go to next, some of the bits that you might not be so comfortable with, or some of the bits you might not be so aware of, and just give you a bit more advice on how to go forward with that, really.
Thank you, Rebecca.
That was a lot of information.
That's a lot there, yeah. You took on an awful lot. So we just thought we'd finish with a question and answer session.
Yeah, if there's any specific, I mean, because we didn't really cover much on seating, surprisingly, it was more about the postural care. We have got chairs with us, so if there was any terminology that I mentioned, or if there's anything you want to see on the chairs when we talk about postural care and how we do that, then yeah, go ahead, use the chat function.
I know there was a little bit of a theme about trying to get care homes to kind of engage with specialist seating and postural care in the chat, yeah. And the way forward for us, what we're actively doing at the moment is promoting training for care home staff. So that could be at a local level where we come in, spend an hour just chatting about the basic features, the importance of tilted space, back angle recline, foot support, elevation, and just generally the improved well-being of a resident, almost a value-adding concept for this, for the service, for the care service that the care home provides. We're also working at a group level with care homes. So we are trying our best to kind of really be evangelical, with the gospel of specialist seating and postural care.
Yeah, another thing that does tend to work well, that from personal experience and my professional experience, is to have care plans in place and actually have individuals to sign care plans. I found that I tend to get a much better compliance when people know that they've digested that information and actually they've signed those care plans to say that they've understood, but making sure that there is a list of reference points for them, that should they be concerned, things to look out for, or if the key worker changes or if there's a new team, contact details so they know then that they can pass that responsibility on as well. So it's not as daunting for them, but I have found that getting individuals to sign care plans tends to work quite well as well.
Any questions jumping off the screen at you there, Jess?
So there was one that came through. So wondering whether we could have some of your advice on this. So it's really difficult to balance safety and prolonged sitting in community. We often discharge patients who are at high risk of falls and advise not to mobilise unless with carers. This means that these type of patients are sitting out for 4+ hours in between care calls.
Yeah, like I said, it's always a balance with seating, and I guess probably the biggest tool it can use is using actually the functions of the chair to get a change of position. So even though maybe they're not mobilizing, but their posture is changing slightly and the effects of gravity is changing. So if somebody, so tilt and space, so as long as it's getting safe and appropriate for them, sometimes tilt and space, and it might be a case that they might need something motorized then as well to be able to do that independently, but that might be the safest, most cost-effective way of having a change of position. Even though they're not mobilizing, they still this gravity is still changing where the positioning is. Leg rest elevation as well, that because they can then get some extension on the knees, so that actually the knees can go through a range of movements. So even though it's a passive range, having an exercise plan, I'm sure that's something you already do anyway, but seated exercises, marching on the spot, arm exercises, anything that just encourages blood flow, and even just repositioning in the chair. So things like wooden knuckles, being able to push themselves just to get some pressure off the bottom sometimes is a really helpful exercise to do. So you can just redistribute that pressure for a period of time and do such as some shifting within the chair. But I totally get that it is a fine balance, and if somebody is unsafe to mobilise, then we do have to manage that.
Yeah, and sometimes that powered option for the carer, perhaps it's an elderly relative looking after a loved one, and perhaps the physical adjustment of tilt and space in a manual chair may be a little bit too much for them. So the thought of that powered option is helpful. Plus, we've got an option called auto tilt, which is like a regulated motion. So you press the button on a powered chair, and the chair will cycle through its range of tilt and space. You can also integrate the chairs into environmental control systems. Not suitable for everybody, but for some it works really well.
Yeah, so if somebody is restricted to a sitting position, then just utilising some of the functions if possible, tilt and space, leg rest elevation to get changes in joint range, getting them to do gentle exercises within the chair, marching, even marching on the foot plates, lifting their feet up and down off the foot plate.
Can you demonstrate?
Yeah, you could do, I can't.
That's just an excuse.
Yeah.
Thanks, Bill.
And if you imagine just doing gentle marching on the spot, and again you get hip range of movement, knee range of movement, and then using knuckles then having a robust chair just to be able to shift within the chair, even just encouraging those can sometimes be enough just to get blood flow and some activity and engagement within the chair, so people are not fatiguing and restricted to one position. Hope that helps.
Thank you. Phoebe did say excellent advice. Thank you. We've also had a question through from Leanne Turner. So what are your thoughts around individuals who have very complex seating needs and have a specialist moulded wheelchair, around the appropriateness of having a separate chair? I often feel that the pressure issues are the same without a lot of functional benefit, but would love to hear your thoughts.
I mean, personally, and from learning disabilities is my area. That's what I've done since I graduated, is what I've specialised in, is learning disabilities, and having as much support to have as many different changes of position has just really been important for comfort, and that's always been a priority of mine, is getting people comfortable. And that's why I said about differentiating the objectives. Specialist seating isn't there to replicate moulded seating. It's there to fill that gap and offer a period where somebody can relax into this support surface, where they can feel comfortable, and where we can maybe try and dampen down some of those abnormal movement patterns that we might see. It's completely different objectives. So it's sometimes it's one of the questions we always get asked about, how do people justify having specialist equipment and wheelchairs, but they're two very different goals in my eyes, and give different people.
It's getting that balance between comfort and posture. And quite often, you know, if you look at somebody's activities through the day, perhaps it's throughout the day in a functional wheelchair,
for transit, for mobility.
Function, they come home, they're fatigued, they go to bed, they lose that kind of social inclusion. Specialist seating allows that person, that 24-hour postural management, to make the most of their day. It provides an alternative, comfortable seating system. It's quite a difficult balance.
It is,
It's sometimes a compromise between comfort and posture. As you said, comfort is key. If the person isn't comfortable, they won't use the product. Yeah,
and it's really strange for me to say not to strive for that perfect posture, because the whole point of this talk is about postural care. But then again, that's the different objectives. When somebody during the day maybe has the energy, or has the tolerance, they can be in that more restrictive, rigid, moulded seating. But then it's the same with us. If we have our office chairs that we need for function, for postural support to reduce the risk of injury and so on, we have that during the day. Then we come home and we adopt different postures to be able to relax and feel comfortable on a sofa, for example. And that's the difference, I think, between wheelchairs and specialist seating. Different objectives, but it also, what I found, especially with some of the individuals I work with cerebral palsy, that obviously they might have those with high tone within their moulded seating, that's completely supported. So what we don't see is much active engagement, so they're completely supported within that rigid system. So they've got the high tone, but they've got this underlying weakness. And what I found is that they engage a bit more within the specialist seating, so that we can try and actually get the muscle strength up that's hidden by that high tone. So again, that's just one thing that I've noticed with specialist seating, gets people more actively engaged to try and use their postural support and their postural control themselves to try and help with fatigue management as well. That's one thing I've found.
Anybody else, Jess?
Thank you. I'll just double check. We were asked if it was possible to reshare the final slide of the presentation, if that's okay.
Yeah, I'll put it up quickly. I will put it out with.
Yeah, we will send you a copy of the presentation and a link to the presentation, the actual visuals. Was
it this one? I think people wanted. This is just everything, that all the resources that we have available. There's an info center on the website that goes into the health conditions, how specialist seating can help for different health conditions, different postural challenges. We've got postural challenge booklets as well that goes into a bit more detail again. Each of the chairs has their own clinical justification documents, bit of a cut and paste exercise. So if you needed that for funding requests, why back angle recline might be needed, why a padded groin harness might be needed. We've obviously got the encyclopedia, which is the comprehensive big book, but then the reference pocketbook as well. That's available to take out and about. There's case studies for each of the chairs. We've got some clinical evaluations on there, some pressure mapping activities, the water cell technology. We didn't really cover that we've got within CareFlex seating. There's been medical devices, Fiona Collins and Carol Bartley and Stevens, who that was published in the Journal of Tissue Viability as well, looking into water set technology. So those clinical briefs are available, and also the live webinars as well. There'll be a bit of a break over the summer, but we do those. And that's not everything. There's lots of blogs and things and all sorts on the website, and things that we can send through as well.
There's a wealth of information on the website. Even
YouTube channel now as well.
If you wanted more information on a chair, how to adjust the chair, there's lots of how-to videos which will isolate the function that you're looking to adjust, that we run through how to adjust that feature on the chair. So seat depth, seat width, foot plate, leg rest elevation, etc., etc. Anybody else, Jess?
That's great. There was one saying, can we get access to previous specialist seating webinars? And yes, you can. So what I'll do is I'll include the link in the post-webinar pack, so you can take a look through all of our previous webinars. But yeah, I think that was all of our questions for today. Okay, well, if that's the case, we'll finish there. It's a record. We're finishing on time.
Yeah, for me.
So thank you for joining us. If there's anything you need, please do get in touch. info@careflex.co.uk. Or is there another email address as well, Jess?
So yes, there's the info@careflex.co.uk, or you can email training@careflex.co.uk, and we'll be able to pick those up.
Okay, thank you very much.
Yeah, thank you. There's a lot of information, so any further reading, just get in touch and we can point you.
Okay, thank you. Bye-bye.
Thank you. Bye.
Bye-bye.